We're pitching to Johns Hopkins University leadership for speech generative AI. We'll be discussing the goal of our project, the problem that has inspired this project, as well as the opportunity we have for a resolution. We'll be proposing a solution to the problem and discuss the cost benefit analysis. We will also review the gap in data sources and data elements, possible obstacles and risks, and what if scenarios. We'll conclude with our implementation and deployment plan and then final words. Our goal is to improve the quality of patient care by alleviating clinician burnout and improving efficiencies in documentation, ideally as measured by the Harris Poll. We also aim to enable patients to take a more active role in managing their health care. Even before the COVID-19 pandemic, studies have shown that clinician burnout has been a growing problem in the United States. There are multiple factors that contribute to clinician burnout, but some of the most frequently cited ones are busy work environment, demands on productivity, demands on time, excessive bureaucratic tasks, and increasing documentation requirements. For purposes of this project, our focus was on addressing the heavy burden of documentation. To add to the documentation burden, it has been noted that poor communication between patients and clinicians can lead to misdiagnoses and negative health outcomes. So clearly, there is an unmet need in the healthcare industry for software to help to reduce provider burnout by reducing documentation burdens, while enhancing communication between provider and patient. The Press-Ganey survey can be used to measure improvement outcomes. I'll now hand it over to Genta to discuss the proposed solution to this problem.
So, in these previous sections, we explain the problem is provider burnout due to the high burden of the documentations. In these sections, to address this problem, we like to propose speech generative AI, which was developed by Average. Average was founded in 2018 with the mission of powering deeper understanding in healthcare. The AI-powered platform was proposed built for medical conversations, improving clinical documentation efficiency while enabling clinicians to focus on to the most their patient. On the next page, we like to explain in more detail how to contribute this AI in a practical situation in healthcare. Okay, so this speech generative AI contributes in two steps. First one, in the patient counseling phase, AI contributes to the reduce the time spent on note-taking. Therefore, clinician can focus more on the patient than note-taking because AI can transcribe and summarize the patient interactions. In post-counseling phase, this AI automatically organizes information from the note into the format and structures documentations. Therefore, clinicians don't need to secure much time for documentation preparations, and they can focus on other important work. Also, based on the patient analysis data by AI, it's a decision support of the diagnosis and treatment option for clinicians. These solutions help clinicians allocating more time to patient care and critical work than documentation work. Furthermore, it has the opportunity to expand the responsibility of the supportive healthcare provider, such as NP and the PA, with AI decision support systems. Eventually, we believe this AI will contribute to the care delivery efficiency and enhance quality care delivery.
Thank you, Genta. I'll now be going over the cost-benefit analysis of utilizing a bridge. Needless to say, AI-based products are generally expensive. The cost of implementing AI tools includes several factors such as setup, training, e-learning material for the staff, and project management. As for the software itself, A bridge charges healthcare institutions with 500 plus providers a monthly enterprise fee that is less than $500 per provider. Given that Johns Hopkins Hospital has around 2,500 physicians, the annual fee for a bridge usage comes out to be approximately $12 to $13 million. While this is a sizable figure, a bridge will ultimately still bring considerable value to your healthcare system. A bridge creates a more efficient workflow by reducing documentation time by up to 53% per note while maintaining accuracy. Within minutes, it drafts notes based on recorded clinical conversations. This can be especially helpful in units like your emergency department. The high acuity and patient volume increases documentation workload, which leads to more stress and burnout, something a bridge can help alleviate. Since 57% of physicians cite clerical burden as a major cause of burnout, a bridge is highly beneficial in mitigating physician burnout and turnover. The annual cost of physician turnover for a hospital of an equivalent size to yours is estimated to be around $21 million. Thus, reducing clinician turnover not only equates to cost savings, but also provides continuity of care for the patients. Other benefits to a bridge include providers having more meaningful patient encounters. Since they can spend less time documenting, providers can focus more on the patients during clinical encounters, which translates into improved quality of care and a better patient experience overall. A bridge also has multilingual capabilities. It can record conversations in up to 14 languages while producing a note in English. This allows providers to serve a wide range of patients from diverse backgrounds. Additionally, a bridge works across 50+ medical specialties. Lastly, a bridge can be easily integrated inside your main EMR, Epic. By and large, a bridge will be a vital asset to your institution. And now I'll be handing it over to my
Thank you, Angelica. Now I'll discuss the gaps and data sources for our proposed solution. First is patient acceptance and satisfaction with AI-generated notes and summaries. While a bridge aims to reduce the cognitive load on clinicians, it is crucial to understand how comfortable patients are with an AI recording of their visits and how helpful they find these AI-generated notes. Another gap is the long-term impact on physician burnout. A bridge has shown promising results in reducing cognitive load and burnout in the short term, but we need longitudinal studies to measure the impact over several years. Lastly is ensuring data privacy and security. As a startup, a bridge is actively working to address these issues, but there is an ongoing need to ensure that all patient information remains secure and compliant with evolving healthcare regulations. A bridge needs to continuously document and update stakeholders on various security and privacy compliances. To address the gap in patient acceptance, we propose conducting comprehensive patient surveys and focus groups. These will help us gather qualitative feedback on their experiences and satisfaction levels with AI-generated notes. Additionally, we can pilot studies to measure patient engagement interaction with these notes through patient portal usage metrics and interaction frequency with AI-generated content. For the long-term impact on physician burnout, we plan to initiate longitudinal studies that track burnout rates over multiple years. By using validated burnout assessment tools and conducting regular surveys, we can measure changes over time and gather qualitative feedback from physicians. This data will help us understand the sustained effectiveness of a bridge in reducing burnout and improving physician retention rates. Addressing data privacy and security concerns will involve conducting regular security audits and risk assessments. We will ensure strict adherence to HIPAA and other relevant regulations with update compliance documentation. Tracking the number of security breaches, incident reports, and remediation actions will help us maintain high standards of data security. By doing so, we can ensure that patient information remains secure and compliant with healthcare regulations that may continuously change.
We will discuss some struggles and risks with our AI system implementation. First, technical risks. Integrating the AI system with existing EHR systems like EPIC can be challenging and may lead to operational disruption or data inconsistency. Error in AI-generated transcription could lead to misinformation, medical error, and misdiagnosis. Ensuring accuracy is crucial and really important. Next, user adoption and training risk. Healthcare providers might resist new technologies, hindering the AI system's effectiveness. Addressing this concern early is essential. Next, proper training and support are vital and important for smooth adoption. Comprehensive training ensures the system is effectively used and reduce resistance. First, financial risk. One major risk is cost overruns. A ramped AI system can be costly, and unforeseen challenge may exceed our budget, straining our financial resource. Another risk is return on investment uncertainty. The ROI for AI systems can be unpredictable. If the system doesn't improve the efficiency and clinical certification as expected, the financial benefit may fall short. Monitoring and evaluating performance is really crucial. Now moving to the operational risk. A significant risk is the system downtime and failure. AI systems are susceptible and sometimes unreliable to outage and failure, which can destroy clinical operations and affect patient care. Ensuring system reliability and having contingency plans are essential. Another concern is the maintenance and update. Keeping the AI system up to date can be challenging. Regular maintenance is necessary but must be managed carefully to avoid disrupting workflow. Proper planning and execution are critical to maintain efficiency. Now we look into the regulation, compliancy, and public policy and perception risk of our AI implementation. These aspects are important for legal compliance and public trust. First, regulation and compliance risk. Protecting patient data is really important. Our AI must comply with the regulation like HIPAA, which can lead to legal action and loss of trust. We need to have the security measure to protect the sensitive information. Secondly, ensuring informed consent is crucial and important. Patients must know how their data is used and provide consent. Proper procedure align with the regulation and build patient trust. Next, public policy and perception risk. Regarding patient privacy concerns, public sensitivity to AI handling health data can lead to mistrust. Clear and transparent communication about data protection is important to build trust. The legal landscape is continuing to changing. We must stay informed and adaptable to ensure compliance and avoid operational distrust. We really need to answer how AI could improve patient transparency. The short answer is to enhance engagement and trust in their healthcare. First, AI provides clear health explanation by breaking down complex medical explanation, helping patients better to understand their condition and care. This leads to more informed patients actively involved in their healthcare decisions. Next, AI also offers real-time updates to patient records, ensuring patients always have the most current information about their health status and treatment progress. This promotes transparency as patients can immediately see any change. AI empowers patients with easier access to their health data. User-friendly interface allow patients to view their medical history, test results, and treatment plan at any time, enabling their decision to take an active role in managing their health. Lastly, AI tailor medical information to individual patient needs, providing personalized health insight. This customization helps patients comprehend complex information relevant to them, enhancing understanding and engagement.
Thanks, Evander. So for what-if scenarios, we must consider data and privacy security first. So if vulnerabilities exist within the AI system, there could also be breaches in patient confidentiality, and this would risk exposing sensitive data to unauthorized personnel. So to mitigate this, we propose strict access controls, advanced encryption methods, and really stringent adherence to HIPAA guidelines. Next, technical problems are also a possibility, so like technical glitches or system outages that could occur during patient interactions. To counter this, we recommend designing the system with offline capabilities to ensure that patient care continues uninterrupted. Another concern is inaccurate transcriptions, which could lead to errors in patient records. Our solution involves incorporating physician review checkpoints and regularly updating the terminology databases to ensure continued accuracy. Integration into existing systems is also very crucial. So if current EHR systems are incompatible with Abridge's software, it could create significant issues. And we propose conducting very thorough pilot and testing phases to identify interoperability problems very early on, with dedicated resources for troubleshooting and proposing necessary adaptations. Lastly, some patients might feel uneasy about being recorded during interactions. And to address this, we provide a clear opt-out option and ensure full transparency about the benefits of using AI. In summary, while these are potential risks, we believe that these solutions will effectively address them.
Thanks, Eleni. I will now discuss the implementation plan to integrate Abridge AI into our EHR system. We will have two phases of implementation: a pilot phase with a smaller population of physicians, and then a full rollout. Pre-pilot activities include picking 10 physicians to test the product. These physicians will be open to change and enthusiastic about technology in anticipation that they could be clinical champions during full implementation. We will then work with the Bridge to develop a training plan for the physicians and train them. As with any new changes, communication is key to buy-in and engagement. We will create and send out email communications and bulletin notices with messaging about a Bridge, why we are piloting it, and the potential benefits to physicians and patients. We will also make it easy for physicians to provide feedback through a dedicated and monitored email, as well as a weekly 30-minute meeting with the CMO and CMIO to discuss feedback. Finally, we will choose impact metrics to track so we can evaluate the success of the product. After we have completed our pre-pilot activities, we will start the pilot program. First step will be to integrate the software into our system. Abridge and Epic were co-developed, so the integration should be pretty seamless. Abridge has said that on average, implementation takes 8 days. After the product is integrated, we will collect and review feedback from our 10 physicians and take this feedback to adjust and respond to issues as they come up. We will also evaluate the product's performance against our chosen impact metrics. If the pilot is successful, we will move on to enterprise-wide implementation. The activities for this will be very similar to our pilot phase, albeit bigger in scale. We will develop a training plan and schedule for physicians, utilizing feedback from the pilot phase in our user training development. Our pilot physicians and the Bridge partners will then train the users. To make sure all our physicians are aware, we will hold a town hall meeting across the system to explain what a Bridge is, the results from the pilot phase, and the potential benefits to physicians and patients. In addition, we will have the physicians who participate in the pilot phase go to individual department meetings to further discuss their experiences and act as change champions to build up buy-in. We will also create and send out system-wide email notifications about a Bridge and the implementation schedule. Finally, we will socialize the feedback mechanisms created from the pilot phase to make sure everyone is aware of how they can voice any comments or concerns. In this bigger rollout, we will suspend weekly in-person meetings and instead hold a monthly optional meeting. Physicians can submit feedback beforehand for discussion. Based on any feedback from the pilot phase, we will choose our impact metrics to evaluate. Much like our pilot phase, we will implement the software throughout the enterprise, further customizing implementation based on feedback from the pilot. In the first few weeks of implementation, we will have at-the-elbow support from trainer physicians at Go Live to quickly help with any issues that new users may experience. We will then collect feedback and evaluate performance, adjusting and responding to issues as needed to ensure smooth integration of a Bridge into our processes.
We'd like to thank Johns Hopkins University leadership for your attention, and we hope that you will consider a bridge for your documentation needs.